Welcome to Modern Medicine here at the Simon Kramer Cancer Institute. I'm pleased, very pleased to have with us the manager of the Cancer Research Institute from Gettysburg. Terry, welcome to the Simon Kramer Institute.
Thank you, Dr. Moylan.
Pleased to have you here. I've worked with you over the last several years, and I'd like you to introduce yourself to our viewers. You have a very interesting background. Could you go over your career path with us?
Certainly. Yeah, I do have kind of an unusual background in that medicine is a second career for me. I was raised in Montana, and I worked, my first career was as an operator maintenance man in hydroelectric power plants. I got that job because I was electronics trained in the Navy more years ago than I care to think about. Yeah. But I worked in that job for over 20 years, had the opportunity to take an early retirement, and I decided to go into medicine. Now, I guess my interest in the medical field started, the first power plant I worked at was way up in the mountains on the edge of the Beartooth Wilderness, which is the northern boundary to Yellowstone Park. Very remote setting. Our nearest neighbor was 14 miles away down a rough mountain road. The road was often closed in the wintertime, so you couldn't get in or out. And we'd have backpackers come through there because the road ended at our plant. And then had summer workers because the summer was only about 2 months long. Wow. And it would snow every month of the year. Yeah. And so we had to sometimes take care of injured people. So while I was there, I became an EMT, emergency medical technician, and really got interested in the medical field. So when I had the opportunity to take early retirement, my goal was to become a nurse so that I could work anywhere and follow my wife's career, because we wanted to get our children closer to grandparents. My wife's from Minnesota, and my parents had long since passed away, so that way I could work as a nurse anywhere. Sure. So we did that. We moved from Montana down to Nebraska, and I got my nursing degree at Creighton University, and then worked at the University of Nebraska Medical Center for a good many years in clinical research and cancer research there. Then I retired, or so I thought. My wife had been headhunted by a company in Chambersburg, where we live, to come work for them, managing and as an administrator in nursing homes. So we thought an ideal opportunity for her to open a brand new facility, and so I retired and we moved out here. I got pretty bored after a short time and realized I had to have something to do, and just kind of came across the position I'm in with Dr. Shaw. At that time, it was a Gettysburg Cancer Center, and he hired me to grow the research department there. We changed our name last year from Gettysburg Cancer Center to the Pennsylvania Cancer Specialists and Research Institute. And so I run the Research Institute there. We have managed to grow it considerably. We do all kinds of studies there, and all phases of studies. Wow. And so it's been a challenge to grow, and it's been very rewarding.
Well, from what I've seen of it, it's very exciting. But as an aside, when you were at the University of Nebraska, you worked with Dr. James Armitage, mm-hmm. who is an internationally known expert in non-Hodgkin's lymphoma.
Yep, worked with him. He was, I don't remember just what his title was. He was way above me. And then also I had the opportunity to work with Dr. Julie Vos, who was the president of ASCO, and is considered to be the best lymphoma physician in the country.
I've referred some patients out to Dr. Armitage years ago. But again, the field of immunology, that's what many of these protocols that are out there concern. And kind of in preparation for today's meeting, I did a little Googling, and I called an old professor of mine from Georgetown University. His name is Dr. Joe Belanti, and this was back in the 70s when I was at Georgetown. And he had written a textbook which was kind of seminal in the field. And I was delighted to find out that he's alive and well at age 89 and still practicing. And next week he's giving some lectures to the medical students and the residents at Georgetown. But back in those days, I was more concentrated on anatomy, physiology, pathology, and there was very little space in the curriculum for immunology. And why hasn't that changed over the years?
It has changed considerably. It's been truly wonderful to be part of this breaking technologies that have come through. I mean, back in the old days, 40, 50 years ago, we treated cancer with cytotoxic drugs that basically killed all the fast-growing cells in the body, which led to a lot of very hefty side effects. People losing their hair, all kinds of other issues that came with it. And at that time, a lot of people, my father included, who died from lung cancer, felt that the treatment was worse than a disease. So as we learned more about how cancer works and how it functions, we've been able to target more and focus down on the cancer cells themselves and leave normal cells alone, which has been a great breakthrough for patients because there's fewer side effects. Many patients on cancer therapy today continue a full life. They work full time and go on about their lives.
Again, what you're describing is the sparing of normal tissues is the famous magic bullet.
Yeah.
And that's been the holy grail in cancer medicine. I'd like you to tell me about Dr. Satish Shah. I've actually known Dr. Shah probably for 35 years when he was training at the Hershey Medical Center, and we would go to quarterly lectures and meetings from the Central Pennsylvania Oncology Group. That is since defunct, but again, Dr. Shah has continued his interest in research.
Yes, he's been involved, from my understanding, in research since he opened up his practice about 33 years ago in Gettysburg. So he's been focused in Gettysburg this whole time and been involved in research the whole time. So he's very interested in the science behind treatments and helping people. His goal is to bring these modern state-of-the-art treatments to Gettysburg, and now we have offices in surrounding communities and now in Philadelphia. So we're trying to bring these new innovative therapies and technologies to the patients so they don't have to travel to these major centers and be displaced from their homes and their loved ones to seek treatment.
Well, and I'm also pleased to tell our viewers that we have an affiliation with your Cancer Research Institute, and that with our foundation, which is called the Educational and Scientific Trust of the Simon Kramer Cancer Institute, we will be able to provide courtesy transportation down to Gettysburg to get evaluated for such treatment.
Well, and along with that, that you can help provide transportation. Many studies, particularly phase 1, and I'll talk about the phases of trials so that we can help educate the public on how they work. Many of these trials will pay for transportation costs. They'll pay mileage, food, they'll even pay hotel bills if you have to come and spend 1 or 2 nights.
Are there out-of-pocket expenses for the cancer patients that are enrolling in these trials?
The FDA has regulations that they have put in place that prohibits any clinical research that that a patient will participate in. It cannot increase the patient's cost. So most of what we do in research is offered free to the patient.
It's a wonderful service. Well, Terry, we're going to break for some commercial details, but when we come back, I'd like to consider a couple of the exciting new protocols that will be available to our patients and the patients in the region.
Of course.
Thanks. Welcome back to Modern Medicine with Dr. Moylan. I'm very pleased to have our guest speaker, Terry Burke, from the Gettysburg region and the Cancer Research Institute. And he's been involved there for 5 years, doing some very exciting research work that will be available to our patients here at the Simon Kramer Institute. But Terry, could you give us a little background on, that's called the immunology of cancer, the cancer cells which are our target?
Mm-hmm. So, as we had discussed earlier, we had the old chemotherapies that were really toxic to the patients. Then we started moving into a targeted field of treatments and what we call immunology or immunotherapy drugs. You have to understand, in cancer cells, cancer is not an invasive body like a bacteria or a virus. It's our own cells that have gone bad. So every cell in the body has to replicate. And to do that, when a cell starts to divide, they have to first duplicate the entire DNA strand, which is the code to build us. So they have to replicate that strand before the cell can divide. Sometimes there are errors made in duplicating that DNA strand. We call them transcription errors. And there are a series of genes called DNA repair genes that will go in and repair that. If it cannot be repaired, then these DNA repair genes turn on another process called, and it kills the cell. So you think about an old Xerox machine where you take and make a copy, then you make a copy of a copy. So if these cells are allowed to replicate like an old Xerox copy machine, pretty soon you have cells or paper that you can't read anymore. And these cells, if they're allowed to replicate, will build and build, they'll clump together, and we call that tumors. Those tumors then need oxygen, they need nutrients. So as that grows, they need more blood vessels. So it was always thought before that these endothelial cells, they would turn on the body's process to build blood vessels into the tumors. And that allowed the tumor then to continue to grow. Some of the early drugs like the sunitinib, sorafenib, Avastin, those drugs shut down that normal process that the endothelial cells use. But we found that it didn't work on everything. And they discovered that there's actually another method where the cells can still get those nutrients and oxygen. We call that a vasculogenic mimicry. And it's a whole nother process using sortilin in the cells to provide all those nutrients and continue to grow. So now we have another set of cells that we can't affect with the immunotherapies that we have. So now they've come up with new therapies that will attack that process. At some time in the future, you and I may not see it, but at some time, we're not going to be calling cancers by lung cancer or kidney cancer or prostate cancer. They'll be identified by the particular genetic mutation that causes that cancer, and we'll have a therapy that targets that specific mutation. We are in the very early stages of that in research today.
But to put it into perspective, I saw a patient in follow-up earlier today, and he was telling me about his sister who has stage 4 non-small cell lung cancer. So it's spread. And she was started not on chemotherapy, not on radiation, but on some targeted agents. And she is actually going to see a specialist in lung cancer down in Philadelphia. And the upshot was that the researcher predicted that she might be around for 10 years on these various targeting of the genetic problem, the driver mutation in the cancer. So I just was thrilled with that. And the other thing that you pointed out was the tumors getting starved for oxygen. And they have these new blood vessels, but they're abnormal blood vessels.
They are.
And that is one of the causes of what we call radioresistance. You need oxygen to kill a cancer cell when you give radiation. So if a tumor is hypoxic, not enough oxygen, it's radioresistant. So I see in the future there's going to be room for interaction between the external radiation and the new immunotherapies.
Well, and these genetic defects in there will also work to make the cell resistant to therapies.
Yeah.
So they will mask and hide themselves from our own immune system, which has a hard time recognizing this because it's our own cells. And so it's not until the cell gets really bad and starts making us sick that the immune system will begin to recognize it. But by then it's a little late and it overwhelms the immune system, and it's still the cancer cells can hide from it. So some of the drugs we use today will remove that ability to mask and hide from the therapies. And that is a great thing because it also reduces the ability of the body to become resistant to different therapies. So those therapies will then work longer and be more effective in controlling the cancer.
Well, Terry, with that background, that scientific background, could you tell us about some of the new protocols that have been activated at your institute and how that's going to help people?
Yes. I probably should predicate this by with a disclaimer that while I work for the Pennsylvania Cancer Research and or Cancer Center Specialist and Research Institute, I am going to present two studies in particular that those pharmaceutical companies are helping to fund this program, and that is OncoC4 Incorporated. They are based nearby here, actually, a couple of states away, so a U.S.-based company. The other one is Theratechnologies Incorporated that's based in Montreal. So those two pharma companies help provide funding for this program today.
Another aside, Terry, we hear on the news, big pharma. My dad worked for Wyeth Laboratories, which was part of big pharma. And my impression was that these companies are very ethically based and they have the interest of the patients in mind as a priority. Of course, there's always a profit motive, but in our country, to attract bright young people to do this grinding research, it's necessary. And like over in Russia, they don't have any new drugs. They give out medals, hero of the Soviet Union, but that's poor compensation for the manpower that we need to get this done.
Yeah, and the pharmaceutical companies, they have a lot of writing on their new drugs. It's very expensive to take a new drug and develop it in a laboratory, take it all the way through animal testing, through human testing to get FDA approval. It takes an average of 10 years, usually it ranges like from 7 to 12 years, to do that whole process at the cost of an average cost of $2 billion.
With a B.
with a B, $2 billion. So that's a lot riding. And I've actually seen companies go bankrupt because they failed for one reason or another. And not all drugs do make it to FDA approval. Fortunately, on some of them, they can be retasked to do something else. There was a drug a while back that failed. It was a drug being tested for blood pressure. Now that same drug is marketed as a hair restoration drug called Rogaine.
Yeah, minoxidil. Yeah.
Yeah. So, it's a very expensive process. So the companies have a lot riding on it. So when they develop these drugs, they take them out to sites because they don't have the patients that they can test these drugs with.
Yeah.
So they have to come to sites like us.
To the clinics, yes.
Into the clinic area. We are able to bring a lot of these technologies in and test them with patients so that they have access to these new therapies. And the exciting thing about that is that there may be a standard of care drug, one that's already approved for their use that can be used at any time in the course of their treatment. But these research drugs, we test drugs from all the way from what we call neoadjuvant, which is before surgery, first time in use, all the way down through the spectrum into metastatic setting and multiple lines of therapy. These drugs are set up specifically in certain areas like that. And if you have some of the standard of care drugs available, it could eliminate your ability to take advantage of this new research opportunity. Whereas if we can look at patients and bring that research opportunity in during different times in their treatment, then we still have those approved drugs sitting on the shelf that we can use at any time to battle their cancer. So it's very important for people to understand that research is not just the last thing tried because everything else has failed. We need to look at people earlier and earlier so that we can eventually cure it. And so it's a very important thing. And one thing that will go along with that I would like to announce for the first time here, at our research institute, we will pre-screen patients for any physician, or if the patients want to contact us directly, we will pre-screen you and try to find a trial. And we will do this free, at no charge to the physician, at no charge to the patient.
That's an outstanding service.
So if we can find a trial, more the better. I can tell you where to access it if we don't have it ourselves.
Yeah. That's wonderful service. Well, can we go over the protocols that are in the pipeline?
Yeah. I want to say here that we are at the cutting edge research. We have brought studies in. There's a drug out there that's a very popular drug right now in the treatment of prostate cancer called Pluvicto. We were involved in research with that drug. It treats prostate cancer with metastatic bone lesions with lutetium isotope.
Radioactivity.
A radioactive isotope. You have to express your PSMA or your cancer has to express a PSMA protein, which is not to be confused with PSA. PSMA is prostate-specific membrane antigen. To find out if your prostate cancer expresses that, we have to do a scan, a gallium isotope-based scan, to determine that. And I think it's about 80% of prostate cancers express PSMA protein. We were the second site in the United States with the capability of doing the gallium scan, and the only site on the Eastern Seaboard. So any facility on the East Coast that participated in that trial, called the VISION trial, had to send their patients to us to get that gallium scan. We are deeply involved in phase 1 research, which is first in human testing. And one of the drugs that I want to talk about here is with Theratechnologies, we were the first in the entire world to treat patients with this new technology.
Fantastic.
And this drug is called, well, the development number is TH1902. They since just told me they've developed a name for it. It's called pseudocetaxel zendusortide. Mouthful of a name. I prefer TH1902.
Yeah.
But that drug, first in human testing at our facility, it is very unique. That drug actually got FDA fast track approval before it was ever given to a human being. I had never seen that happen before. The FDA is trying to cut down on a lot of the red tape so that drugs can be brought to market faster.
Yes.
And reduce the costs and the duration so that people can have access to these technologies sooner. This particular technology utilizes a brand new peptide chain that they developed, that Theratechnologies developed. That chain has attachment points for various chemotherapies. They've started out attaching 2 molecules of docetaxel, which is a long, well-established chemotherapy drug that fights many different cancers. We then infuse this into the patient. That peptide chain utilizes what we call the sortilin receptor, which many cells in the body express. The problem with sortilin is that in cancer cells, sortilin is overexpressed and leads to cancer and makes the cancer worse and to grow faster. By injecting this, utilizing the sortilin receptor, it's a very fast through the cellular membrane. And if you think about cells in getting nutrients and different things into the cell, it has to have an attachment point on the cell surface. So it's got these little kind of, if you think about a satellite, a round satellite, and it's got these different antennae sticking out of the satellite that's good for different frequencies, or in this case, different drugs. The sortilin receptor is one of those that then takes it directly into the cell, into the deep part of the cell, where it's then distributed out to the different parts of the cell. And in cells that overexpress sortilin, cancer cells, with that docetaxel attached, it kills the cancer cell and pretty much leaves normal cells that don't overexpress sortilin, leaves them alone.
Terry, this sounds like a guided missile.
It exactly is.
Could you tell us how patients can access these protocols, and we'll put that on the screen?
Yes. If you contact the Pennsylvania Cancer Special and Research Institute, you can call down there, ask for the research department, or dial my extension 131 directly. You'll get me, and I will be happy to talk to you about your cancer and if there's any studies. You can contact your doctor, who could then set up a referral, or you could even, just work with us directly, and we could do it that way.
All good things have to come to an end, Terry, and I again thank you for making the trip from Chambersburg, Gettysburg, up here to New Philadelphia. And one of the things that I recall from H.G. Wells, who wrote The Invisible Man and War of the Worlds, his wife had cancer, and he came up with the saying that the motive to cure cancer is not the horror or the pity, but the need to know the how and the why. And that's what you're doing down there at Gettysburg.
Yes.